morning and good afternoon. I'm Jackie Hauser, Senior Marketing Manager at Siemens Healthineers, and I would like to thank you all for joining today's webinar on pre-analytical variables in coagulation testing. We're very excited to host this webinar with Labroots today. Pre-analytical variables and unsuitable samples can account for up to 70% of lab errors. These errors can be attributed to improper specimen collection, specimen transportation, specimen processing, and/or storage. For coagulation, challenges both outside and inside the laboratory's control can mean the difference between accurate and potentially inaccurate results. In this webinar, Dr. John Mitsios, clinical consultant at Siemens Healthineers, will teach you about patient variables, specimen collection, processing and storage, as well as conditions and substances potentially interfering with the testing of different coagulation parameters. Dr. Mitsios has his PhD in chemistry from the University of Ioannina, Greece. He completed his postdoctoral fellowships at the University of California, San Diego, and his clinical chemistry fellowship at Washington University in St. Louis, Missouri. His primary research interest throughout education and training has been coagulation, with an emphasis on platelet function biology. Dr. Mitsios has been a member of the faculty at Weill Cornell University and is an assistant professor of pathology and laboratory medicine, as well as an assistant attending clinical chemist at New York Presbyterian Hospital. Most recently, before joining Siemens, he was assistant director of the special coagulation laboratories at BioReference Laboratories. Additionally, Dr. Mitsios has co-authored 21 peer-reviewed articles and 3 book chapters. And with that, I will now hand it over to you, John.
Thank you, Jackie, for that introduction. So before we start our presentation, I just like to start off with some objectives or learning objectives for today's talk. So the first thing we were going to try is to identify proper coagulation sample collection techniques, as well as how to identify proper sample preparation for coagulation testing. In addition, we'll explain some of the effects of pre-analytical variables on coagulation testing, and finally define the effect of time and temperature on coagulation results. So as we look at the sample journey from patient to that of results, we can see that there are 4 distinct pillars that could potentially affect or could result in spurious results. For today's talk, we're really going to focus in on pre-analytical variables, which consist of obviously collection, transport, processing, and storage. We can also we'll touch briefly on analytical as well as the post-analytical, and finally a little bit on the interpretation of those results. But a common theme tying these 4 pillars is proper clinical history. So you'll hear me talk about clinical history in patient throughout this presentation and the importance of establishing proper lines of communication between both the laboratory and the clinical service. So when we look at pre-analytical variables, they're commonly lumped into those of what are referred to as medical errors. An interesting statistic is that about 1 million injuries and approximately 44 to 98,000 hospital deaths occur annually as a result of these medical errors. And of course, when I created this presentation, that number could not be higher. Initially, medical errors was about the 8th leading cause of death in the United States. And I just decided to Google this morning and say, okay, does this still hold true today? And in fact, medical errors is the 3rd leading cause of death behind that of heart disease and cancer. About 2.4 million extra days of hospitalization and a possible increase of hospital costs by about $17 billion is a result of these medical errors. But what portion of that is really contributed to that of the pre-analytical phase? In a study that was conducted in 2013, it was a 650-bed hospital, and it showed that approximately $1.2 million per year in extra costs were attributed to that of pre-analytical variables. In addition, they kind of drilled down and calculated the average pre-analytical error cost per patient type, comparing both North America and Europe. And we look at the three categories, critical care, inpatient, and outpatient, which includes the ED, you'll see that overall the costs were similar in pre-analytical costs, that is for both North America and Europe, with the exception of the outpatient, which includes the ED in North America, where the cost was about 3 times as high as that of Europe. And that's kind of an interesting statistic right there. In addition, when you drill down even deeper, well, what effect do these pre-analytical variables have on, let's say, patient itself? You can see the increase in cost, close to 75% of that, is really added or additional treatment costs as a result of these pre-analytical variables. And I'll give a couple of examples as we go through the presentation of what this added cost could potentially look like, but not only added cost, but additional anxiety to the patient. So in general, the pre-analytical issues can occur either outside of the laboratory or in the laboratory. When I talk about outside the laboratory, I'm really referring to where the blood is essentially drawn. But it also could indicate that the blood is drawn at an outside hospital institution or a doctor's office. As many hospitals are currently involved in large outreach programs, the outside of the lab or the collection of the specimen may actually happen outside of the laboratory. So that's what we're really focusing on, the specimen collection, the phlebotomy procedures that are involved, and how the blood is essentially collected from the patient and then subsequently processed and then eventually sent over to the lab. In that transition phase in which that specimen is either being transported to the lab, either via a pneumatic tube system, for example, or via a courier service that's transporting from the hospital or the doctor's office to the laboratory, we need to ensure a number of factors that are maintained to ensure the stability of the specimen. I'll touch on those as we go through. And then finally, when the sample is finally reaches the laboratory, how the sample is processed, the centrifugation techniques, and how the samples are stored all play a role in ensuring accurate test results and ultimately improving patient care. So we look at those 3 buckets, the sample collection, the transportation, and the processing. From a specimen collection, this is where the clinical history and the patient itself plays an important role. This is where there should be open lines of communication between the laboratory and the clinical staff to ensure that most recent clinical history is provided to the laboratory, especially in the context of anticoagulant medication the patient may be on or other medication the patient may be on, specifically looking at the patient's age, the gender, and whether or not the patient is undergoing some type of inflammatory condition. Are they currently sick? Have they recently suffered a thrombotic event? All of which play an important role and could potentially affect your coagulation testing. And of course, the phlebotomy procedure, how the blood is essentially collected, what type of processes are involved, what type of needle size, tourniquets, all tourniquet concentration, or tourniquet techniques, a tube size, anticoagulant that it's used, and of course, making sure that the fill volume and the hematocrit are appropriate, because in certain cases, if the hematocrit is too high, there may be a need to adjust the anticoagulant that's being used. When transferred to that second bucket of that transportation, again, focusing in outside of the laboratory, that is in the doctor's office where the sample is being drawn and then subsequently sent to the lab. The distance that the sample has to the distance the sample has to travel. The temperature, high fluctuations in temperature. As we transition to the winter months, obviously maintaining a warm ambient temperature, as ambient as possible, of that sample is important to ensure that the sample is protected and it's not affected by these large fluctuations in temperature. How are the samples positioned? Are they stored? Are they racked? Are they upright? Those also play an important role, as if the samples are loosely put into a container system and as they freely move around, that could result in an agitation and or activation. Within the hospital system, this is where the pneumatic tube system really plays an important role. How the distance, again, traveled from one ward to the other? Is it the number of G forces, for example, the sample is experiencing as it goes through the pneumatic transport system? Are they hand carried? Of course, if we're talking about platelet function assays or any aggregation assays, the samples should not be sent through the pneumatic tube system. They should be hand carried or delivered to the laboratory. How long does that process take when the sample is drawn to when it's delivered to the laboratory? And of course, any fluctuations in temperature, all of which result in specimen stability or sample stability. Because again, the longer it takes the sample to get from point A to point B, which being the laboratory, the higher the probability that there may be some influences of either drugs on board that could potentially influence your testing. And that third bucket is that processing and storage. How do we process that specimen? Especially depending on the test that we need. Do we do a single centrifugation or do we do a double centrifugation? At what speed? What should the platelet count be within that sample that's being prepared? And then how do we aliquot, freeze, and potentially thaw if add-on tests are created? These are standard operating procedures that most laboratories have established. And of course, the condition of the specimen. Are there interferences, such as hemolysis, icterus, or lipemia? Are they clotted? All of which need to be addressed from the pre-analytical perspective before the sample is even put on the line or within the analyzer for testing. And it's really interesting that pre-analytical errors account to up to 70% of the lab errors that we see. And interestingly, the majority of those samples are hemolyzed specimens or hemolyzed samples, in which the hemolyzed samples can have negative effects on medical care by resulting in some type of interference from us being able to get the correct result. But also when we look at those other categories, underfilling, maintaining that blood to anticoagulant ratio of 9 parts to 1 is really important to ensure that there's proper anticoagulant within the sample. Icterus and lipemic samples, of course, can have adverse effects on coagulation testing. Again, this is a very similar slide to the previous, but more breaking it down to the 64% are really the hemolyzed specimens. 10% are those insufficient samples, so those samples perhaps that are not properly filled, that are filled below the recommended fill volume that typically manufacturers put on their tubes. Or we have incorrect samples, an EDTA sample that was sent to the lab, a serum sample that was sent to the lab, an inappropriate sample that does not allow us to get coagulation results. And of course, those others could be lipemic samples, icteric samples, or other samples that are other interfering substances that could potentially affect our coagulation testing. So why is it important? And why do accurate results really, truly make a difference? And I think I gave an example before of how the misdiagnosis actually add to treatment costs. Understanding the importance of diagnosing these conditions, for example, von Willebrand disease, is uniquely challenging to diagnose because of the positive acute phase reactant nature of both von Willebrand and factor VIII, but also perhaps on when the samples are properly drawn. So what happens if a patient is diagnosed with von Willebrand disease? One, they carry this lifelong designation of having von Willebrand disease, so that could potentially affect their quality of life, or it could add additional cost to their treatment, especially if they're about to undergo a surgical procedure, or they're given DDAVP in order to protect them from bleeding. So again, accurate diagnosis, accurate results truly make a difference. For another example is what happens if you have low or high anticoagulation monitoring effects. Well, that could result in the patient being at a higher risk for thrombosis due to under anticoagulation, or at risk for bleeding due to over anticoagulation. So being able to provide those adequate, correct results truly do make a difference in patient care. So the first thing that I want to touch on is really looking at patient variables. And when we look at patient variables, it also is encompassed in the patient's history, as I mentioned before. Again, open lines of communication. Communication is the key between a good laboratory and a good clinical consultation, which ultimately improves that patient care. So we look at the gender of the patient. We look at the age. Is it a neonate? Is it a pediatric patient? Is it an adult? We look at blood groups. Blood groups play an important role. Because, for example, in patients who have a blood group O, they typically have lower von Willebrand. resulting in perhaps a misdiagnosis if you don't know the patient's blood group. The patient's health status, the stress of the patient. Is the patient undergoing a very stressful situation? Pregnancy. Those are all conditions that can potentially affect and influence your coagulation testing. And of course, we look at the phlebotomy procedure. Is it whole blood versus tube collection? Is it the tourniquet technique? Did the phlebotomist leave the tourniquet on for a couple of minutes? Did that result in hemoconcentration in the patient's arm, resulting in higher values? Tube size. The anticoagulant to use, is it 3.8% sodium citrate? Is it 3.2? And I'll talk about those in the coming slides. And of course, the order of blood draw. Do we need a discard tube? Do we not need a discard tube? What is the order of draw? Fill volume and hematocrit adjustment are all important factors that we have to take into consideration as we're taking the sample from the patient and then processing and collecting that sample. We also have to be cognizant of biological variations. So for example, a patient has a high vitamin K food diet, that could potentially adversely affect the vitamin K therapy, therefore decreasing your INR, resulting in perhaps under anticoagulation, therefore needing to up the dose of warfarin therapy. Caffeine. I'm a victim of drinking a lot of caffeine, so if I go in and get a platelet aggregation assay done tomorrow, of course, my aggregation response may be blunted by the amount of caffeine that I consumed. Smoking. Not only is it an increase in cardiovascular disease, but it can also increase various procoagulants, giving the impression that you have a hypercoagulable state. Exercise. Exercise, as we know, is a condition in which we are tearing and building new muscle. So it is a pseudo-inflammatory response. If you think about it in this particular context, you would have your positive acute phase reactants being elevated. So if you immediately take a sample after the patient has exercised, you could potentially get higher values, perhaps masking a deficiency because of those higher values. Specifically, let's say for von Willebrand disease, because of the positive acute phase reactive nature of that protein. We also focus in on newborns, right? Neonates versus pediatric, different reference intervals, for example. Medications, the effects of anticoagulants like warfarin, direct thrombin inhibitors like argatroban, or anti-10A inhibitors or like rivaroxaban or apixaban, all could have an effect on your coag testing. As we age, that also results in changing of our coagulation cascade or coagulation factors. Inflammation, as I mentioned before, high inflammatory responses result in extremely elevated positive acute phase reactants, perhaps masking deficiencies if there are any. I also mentioned the fact that there are gender differences. For example, in women undergoing throughout the menstrual cycle, there could be variations in fibrinogen levels, von Willebrand activity, and antigen. Knowing perhaps where the patient is within their menstrual cycle, if you're considering a deficiency, may be important for the laboratory to also know, not so much for the testing aspect, but more for the interpretation side. Again, menopause can increase various coagulation proteins. You can have pregnancy. Pregnancy is considered a kind of a low-grade intravascular coagulation or inflammatory response. So you'll have increases in various coagulation proteins like von Willebrand antigen and factor VIII activity, but you could also have decreases in natural anticoagulants like protein S. So not wanting to diagnose a patient with thrombophilia in the context of a pregnancy is an important concept. And finally, hormone replacement therapy, for example, can increase various proteins as well as decrease various proteins. So knowing some of this information, getting that accurate clinical history allows the lab to do its job more accurately and correctly. But it's also being cognizant of the time to when we are doing testing. So for example, if you're doing a thrombophilic workup on a patient because they've recently suffered a thrombotic event, does it make sense to draw the patient's blood immediately after the thrombotic event when the majority of your coagulation proteins will be already decreased? The answer to that question is most likely no. So developing some type of clinical guidelines that the ordering physicians, that can assist the ordering physicians in assessing and drawing these patients at the appropriate time, especially if they're non-hematologists, is really important and critical. Again, ensuring accurate test results for the patient. Another example is heparin therapy, right? Depending on if the patient has antithrombin that's decreased, you could have depressed results for your heparin. Knowing some of this information, being able to adequately assess it is important. Again, and I'm going to say this multiple times throughout this presentation, but remember, we're all in the same business to ensure good results that improve patient care. What also can be confusing many times for our clinicians is the order sets themselves. If a physician is interested in ordering a factor V Leiden and they see a factor V on the order set, they'll go ahead and order the factor V. And then all of a sudden they get a factor V activity and really not knowing what to do with it because that's not what they wanted. So having distinct order sets that are not confusing are also important to eliminate some of these pre-analytical or errors in general when talking about specimen testing and collection. We also know there's an effect of various pharmacological agents on coagulation testing, specifically those of the anticoagulants. Heparin, as an example, is typically monitored using the APTT method if you're on unfractionated heparin, but anti-10A if you're on LMWH or low molecular heparin and or on fractionated heparin. Now, granted, the majority of the labs are moving away from using the APTT-based assays, but I won't get into that for this particular presentation. But the impact of heparin as an anticoagulant has on coagulation methods is quite profound. It can affect your lupus anticoagulant testing. So by diagnosing or trying to diagnose the presence of a lupus inhibitor while a patient is on heparin or anticoagulant medication may be challenging and may result in falsely abnormal results, as well as your PTT-based single-factor assays may be influenced. If your patient's on a vitamin K antagonist, like warfarin, you typically monitor those results, those patients using a PT-INR. But you can also have an understanding that those assays or that anticoagulant may affect your lupus testing, your PT-based single-factor assays, or your vitamin K-dependent factors for that matter, including protein status and protein C. And most oftentimes what we'll see now in today's clinical lab are the new NOACs, or the new oral anticoagulants, or DOACs, the direct oral anticoagulants, where they could be anti-2A inhibitors like argatroban. They could be monitored by specific calibrators against that particular drug. Or you can have the anti-10A medications like your rivaroxaban or apixaban. And this is important. And knowing this information could perhaps allow you to choose which is the more appropriate test. And I'll just give a quick example. Having antithrombin, measuring its activity, can either be done using a 10A-based assay or a thrombin-based assay. Sometimes, if your lab is lucky enough to have both, knowing that the patient's on a direct thrombin inhibitor, it would make sense to not run it on the thrombin-based, but to run it on the 10A-based assay because it won't be influenced. And of course, the opposite holds true if your patient's on an anti-10A medication. But again, the impact on the coagulation testing is, again, quite profound because you can have falsely abnormal results in the context of lupus testing, in the context of determining factor assays, and therefore it's important to have that adequate, appropriate clinical history. And of course, there's a couple of more examples here indicated in the slides. So let's talk a little bit about sample collection and processing. And again, everything begins with the sample. The higher the quality of the sample, the better it is for the testing that's going to come out. And you'll hear me say this again, but Donna Castellone, who I believe was the lab manager or is still the lab manager at Columbia University, she said that 4 hours is equal to good coagulation and 2 hours is equal to great coagulation. So the faster your specimen, the higher quality the specimen gets to the laboratory, the better it is for the patient. So if you look at the definition of a phlebotomy, it's the act of venipuncture that initiates the hemostatic response. It's exactly what happens. So as the needle penetrates the skin, it activates the coagulation cascade. So it's important to follow specific guidelines that allow us to minimize that effect to when we take that sample and put it into our situated tube. But we also have to be wary of the body position. So we know that hematocrit increases lying, sitting, and then standing. So that results in kind of reversible hemoconcentration or the redistribution of blood. So it's important that to know that if the patient is about to get any type of hemostasis testing, have the patient sit for a period of time, at least 20 to 30 minutes before the hematocrit adjusts, and then be able to draw the patient's blood to ensure that there isn't a hematocrit effect, let's say, or a position or a body position effect on your coagulation testing. But some other factors we have to take into consideration is the sample size, or the small size of the needle. So if the needle has a small aperture, you could imagine as you're pulling the sample, you're causing platelet disruption, which could result in hemolysis. So not only are you releasing bioactive components from the platelets, but we're also introducing a hemolytic component. The gauge of the needle plays an important role. How the syringe draw, is it drawn quickly, or is it drawn steadily? How does the syringe, how is that drawing procedure? What does that drawing procedure look like? Is it drawn through a butterfly or an indwelling catheter? We also take into consideration the tube type. What type of tube are we using? Is it an evacuated blood collection tube, which is the preferred method, or are we using a siliconized glass or polypropylene plastic tube? And the tourniquet, no longer than 1 minute, because the longer that we leave the tourniquet in place, the more hemoconcentration that results, the higher likelihood of getting an activated specimen. So these are all factors that we have to take into consideration as a sample is being collected. Another really important factor is the order of draw. And I'm pretty sure that many laboratories have a very similar diagram in their labs. The first thing is you draw the blood and put it into a blood culture tube. Send it off to the micro lab. And the second should be your coagulation testing. And you'll see on the bottom in those gray boxes, it says the number of inversions. And that's important to also adhere to, is you want to make sure that you properly mix the blood to anticoagulant to ensure that the anticoagulant is evenly distributed throughout the sample to prevent any type of coagulation or any type of activation of your coagulation cascade. The recommendation is about 3 to 4 times of gentle inversion. But there also are some nuances to the collection, to the order of draw. Well, for example, what if a patient just wants to get a coagulation testing? So again, this is defined typically within the SOPs of the laboratories. But if there's a single coagulation, or let's say a PT and or PTT needs to be done or drawn on the tube, on the patient, then typically a discard tube is not necessarily required. Because in the order of draw, if you follow it, that discard tube essentially is your microbiology, right? But remember, any type of activation of your coagulation cascade, because both your PT and PTT are global indicators of coagulation, they're not as affected by not having that discard tube. But again, this is defined within the lab's standard operating procedures. But for other analytes or other factors for more specialty testing, perhaps a discard tube is needed to ensure that those analytes are not affected. So drawing 1 or 2 mLs, removing, and then drawing the remainder, the rest of the blood to put into your sodium citrate tube may be more appropriate for those other analytes. If we're using a butterfly, a discard tube probably is required to at least 1 fill volume to ensure that when you put in the blood, you're maintaining that blood to anticoagulation of 9 parts to 1. And if you're using an indwelling catheter, probably want to flush with about 5 ml of saline, discard about 6 dead space volumes of the tubing, and that minimizes heparin contamination within the catheter itself. So again, varying techniques to collect the blood, but again, typically defined within each individual laboratory's standard operating procedures. I talked about mixing the tube, and this is a really important statement. So upon blood draw and upon putting the blood into the sodium citrate tube, it's immediately invert gently, end over end, about 3 to 4 times. And I have seen in the past, when blood has been taken from me and coag test is needed, what they would do is they would draw the blood and really just do kind of this excessive shaking of sorts and then put it into the container tube, not in the most elegant way. In this particular case, what is needed, again, is gently to invert, avoid the excessive shaking of the sample, and then gently placing it into the container, the collection container, before it's distributed or sent to the laboratory is important. Of course, it's also important to look at the tube fill. Most oftentimes, the manufacturers have a proper fill line. It's indicated on the label. It's typically between that 90 and 100% mark. Avoiding either underfill or overfill is important, and I'll talk about that in the coming slides of why that's important. And of course, using 3.2% sodium citrate is more forgiving to underfill. However, and that is the recommended anticoagulant of choice. And the reason for that is one is able to bind calcium, therefore preventing clotting. And as we see, and as we know about coagulation testing, after we've added all our reagents into the reaction vessel, we then add calcium, which is the initiator of the clotting cascade. So sodium citrate effectively is able to bind to calcium, preventing the activation. But there's also another anticoagulant that has been, and is still on, I believe, still on the market. That's 3.8% sodium citrate. Now, the reason that 3.2 is the recommended one is that not only is it's more forgiving and to improper blood to anticoagulant ratio, but also mimics that of plasma osmolality. So if your reference ranges, for example, have been established using a 3.2% sodium citrate, and your blood is run at 3.8, there will be some differences because the 3.8 typically has more prolonged ranges. And the opposite, of course, is true if you've established your ranges on 3.8% and you're using 3.2 in your patients, your reference ranges most likely will need to be reestablished. And the reason I bring that up is if you're looking to get normal pool plasma to establish reference ranges, some vendors may indicate in their websites what type of anticoagulant has been used. So it's good to look and verify that it's 3.2% because that's typically what's used in laboratories today. So is there effect of using a different anticoagulant in our sample? And the answer to that is yes. And so again, here you have a nice table that has 3 columns that looks at different anticoagulants: sodium citrate, 3.2% that is, EDTA plasma, and serum. And I often joked or questioned or quizzed, that is, my medical students or residents, and asked them, what is the difference between serum and plasma? And unfortunately, there were many times that I just got blank stares because I think it was such an obvious question that they were like, the answer can't be this simple. But we know that serum doesn't have our coagulation proteins, right? Because it's consumed them. It's basically resulted in a decreased amount of coagulation proteins. So if we send a serum sample to the laboratory, you would expect to see a no clot or a significant prolongation in your routine tests like PT and PTT. But interesting, when you look at EDTA plasma, you still get a response, right? Because what does EDTA do? EDTA acts in a very similar way of that sodium citrate acts, that it chelates or binds calcium. But it binds calcium in a much more efficient manner. So in the context of centrifuging, you're not getting rid of that very strong binding capacity of EDTA. So what you're going to get is you're going to get prolonged samples. So if you do suspect that the patient sample does in fact have EDTA, most oftentimes the tubes that are used are potassium EDTA. So one thing that could be done is actually send that sample to the laboratory and have a potassium run on that sample. And what you would see is superphysiological values of potassium, indicating that the potassium EDTA tube was used for that particular plasma sample. Because sometimes there could be a mix-up in the blood and it's sent and put into a wrong tube and sent for coag results. And of course, your sodium citrate tube is the desired anticoagulant of choice. So why is it important for clotted samples and why they must be rejected? Well, if we look at clotted samples can have one of two possibilities. They could have prolonged PTs and PTTs because the fibrinogen is essentially and all the clotting factors have been consumed, and you have formation of a large clot at the bottom. But you can also have a shortening of your PTTs, for example, or your PTs, especially if it's a process that's slowly moving to consuming your entire coagulation, your coagulation proteins. So it's that initial phase. So it's an activated sample. So it's another good example of looking at those microclots or microfibrin strands. So oftentimes laboratories now, what they do is they'll take one of those wooden applicator sticks, and they would look and gently look at the plasma to see whether or not there are any fibrin strands that are available. That could indicate that of a clotted specimen. So if a clotted specimen is spotted, of course, it should be rejected and asked for a redraw. So, and these are just some examples that I've heard or read in various textbooks. So some of these things can happen. As an example, if a clot is in fact noticed in a tube, the clot may be removed and the sample is still sent to the laboratory, not realizing that that sample is going to give inaccurate test results. Another example here is an intern collects multiple test orders in EDTA and subsequently realized that a different collection tube was required. So what does the intern do? Removes the EDTA tube, removes or uncaps the EDTA tube, and pours it into a sodium citrate tube and sends it to the laboratory. Now you can imagine that if you do get that in a sodium citrated tube, you're going to say, okay, it's normal, but you're going to get results that clearly don't make sense. Or the sample is drawn through an indwelling catheter without properly flushing. So therefore, there's going to be some type of heparin contamination. Or the sodium citrate tube was drawn, but it wasn't and sent to the lab without properly mixing that sample. And therefore, you're going to get an improper anticoagulant in the blood or mixing, and therefore your samples are going to coagulate or activate. So these things can happen in the clinical laboratory. So that's why it's also important to not only educate our clinicians, but also educate the staff that's drawing the blood of how we need it in the lab to be in order for us to get accurate test results for our patients. So again, we focus on the transportation side, again, ensuring that there's an ambient temperature, that there's not these huge temperature fluctuations. When I talk about the outside of the lab, again, if the sample is collected in a doctor's office and it's being transferred to the laboratory, it's important to maintain that ambient temperature or as close to an ambient temperature as possible. Again, as we approach the winter months now, sudden drops in temperature depending on where you're located within the US, what could happen is you can, wanting to maintain that ambient temperature as possible. Time is really important, especially for coag testing. For example, if the samples are within the hospital system, 4 hours is the minimum amount of time, is the maximum amount of time, right? What I said before, 4 hours equals good coagulation, 2 hours equal great coagulation. If the samples are being sent, for example, from an outside institution as part of an outreach program, the samples then should be frozen and then sent to the laboratory to minimize that time and to ensure that we get accurate results for our patient. How the samples are transported are extremely important. Racked, position, upright, minimize agitation. If we're looking at pneumatic transport systems, assessing the pneumatic transport system. There was an elegant study that was done, I believe in 2006 by my alma mater, Washington University. And what they essentially did is they were able to take an iPhone and they stuck it in the pneumatic tube system, if I remember correctly. And there was some type of app that they were able to download. And they took that sample and they went to different locations within the hospital and just sent it to the lab. And they measured the G-force that the sample would undergo as it's going from various locations. And they saw that there was a difference. Now, this was done on chemistry testing, not so much on coag. But again, having a general understanding of the effects that the pneumatic system could potentially have is important to implement policies and procedures in place to account for that. So if we kind of take a 30,000-foot view, from a pre-analytical phase, looking at the centrifugation, the different types of techniques that we would have to undergo, how the sample is prepared, how the sample is drawn, of course, that's before it comes to the lab. Aliquoting, freezing, and thawing if needed, right? Then we look at the analytical phase. We look at hemolysis, icterus, lipemia, look at Filvon, clotted samples. Those are things that we have to take into consideration. And I'll talk about some of those more automated processes that are available on some automated analyzers in the coming slides. And of course, we look at that post-analytical phase, how the samples are stored, where are they stored, what type of freezer is being used. If an add-on assay is requested, what are the thawing recommendations that the lab has implemented to ensure that the sample is of good quality before it gets to the analyzer itself. Because we know that temperature can play or wreak havoc on some of these coagulation proteins. Increased temperature, for example, can degrade some of our coagulation factors. Refrigeration of whole blood can cause active factors to go up. So there's a number of things that we have to take into consideration. And again, that same comment right there that talks about good coagulation, 4 hours, great coagulation is 2 hours, is important. Because depending on the sample, how the sample is sent to the laboratory, if it's sent as whole blood or is it processed as plasma, different temperatures can affect the samples. Most oftentimes, if the samples are sent from an outside outreach facility, they'll be sent as frozen. This is where you would freeze the samples at -70, and then there's a specific shelf life that the samples are good for. Perhaps doing internal studies to define at what time point you feel comfortable in accepting those samples. I did that in my reference lab where I looked at -20 and -70 and saw at what time point would I be concerned about the results that we're reporting from these samples. For example, if you look at PT, you can keep it at room temperature for up to 24 hours if you have aliquoted already from plasma, but for PTT, for 4 hours. If you try to refrigerate, your PTT is going to be unacceptable specimen quality. So therefore, it's ideal to keep everything at an ambient temperature so you're able to do all your assays and all your tests. Centrifugation, again, the goal is to have platelet-poor plasma that have a platelet count of less than 10,000 per microliter. The recommendation is doing 1,500 Gs for 15 minutes at room temperature, using a swing-out bucket rotor, and double-checking and verifying your centrifuge and your platelet count every 6 months to ensure that you're maintaining that low platelet count. Once the sample is processed, it can be sent to the lab and done immediately, or it can be frozen at -20 or -70 in a non-frost free freezer. Sorry. Why do we use platelet-poor plasma? Well, platelets are a source of phospholipids. So it's important that if we are, let's say, to do lupus anticoagulant testing, that it could influence or could cause a false abnormal result, or even a low result because of the higher phospholipid concentration. So removing platelets. Platelets are important because they carry various bioactive compounds. So platelet factor 4 has been shown to neutralize heparin, right? So therefore, if you're using PTT to monitor heparin, in this unfractionated heparin in this case, it could shorten your PTT, resulting in either undercoagulation or within the normal range, but even though the patient was essentially being over anticoagulant. So it's important to ensure good specimen and good platelet-poor plasma. Of course, because if we're also using freeze-thaw techniques, it's important to have platelet-free, because platelets can also release platelet factor 4 when either cold or frozen. So you can imagine when they're thawed, there's going to be more platelet factor 4, resulting in a decrease in some of your assays. So again, being aware and being cognizant of why we need to use platelet-poor plasma, that's why it's important to verify our centrifuge to ensure that we have a low platelet count. Preparation for frozen aliquots, how they should be processed is important. Again, there should be steps within the laboratory that identify rules and procedures that are in place, but typically thaw rapidly at 37. I, in my lab, used about 5 minutes, and allowed the samples to equilibrate for about 10 to 15 minutes at room temperature before placing them on the instrument. But again, that should be, each individual lab has their own protocols in place. These are just some examples where if you exceed that 4 hours, then it may be hard to add on assays, or may be hard to interpret some of the assays because of factors being decreased. Your platelet results may be poor, or if you have a clotted sample, again, factors that are extremely important to interpret some of the test data. If you have an uncapped tube, very similar to chemistry assays, right? When we have a change in pH, that can lower your PT or PDT results. So again, maintaining that sample quality and stability is really important to ensure these accurate results. In the interest of time, I'm going to skip over this slide because I think I am kind of running a little long here. So I want to touch on hemolysis, icterus, and lipemia. These are the common interfering substances that we see in the clinical laboratory. So we know that hemolysis is really the act of destroying cells, right? So these cells will release ADP or other type of procoagulant factors, which inevitably will result in platelet activation, as well as the activation of the coagulation cascade, resulting in shortened results or results that are not interpretable due to spectral interferences, depending on the clot detection system that your analyzer is using. And if you're using a photo-optical clot detection system, you may be subject to some of these pre-analytical variables from hemolysis, icterus, and lipemia. And it's not to say that the mechanical clot detections are not subject to the same type of interferences. In my previous life, I did use a mechanical clot detection system, and I had established my own ranges for HI and L. But with that said, if you're using a multi-wavelength detection system, you can effectively see that if you are hypothetically measuring your clots at 575, I'm just throwing out a number here, but you can have an alternative wavelength at 800, you can say you can minimize some of the interferences if you are to see hemolysis, for example. So having these techniques that are readily available in clinical labs are really important. Again, this is just a repeat of the slide that I showed before, indicating, again, the importance of these hemolyzed specimens, in which they contribute to about 70% of the lab errors that we see in the clinical lab. And hemolysis is the most relevant parameter of the interfering substances that we see. And it really is independent of the measuring methodology. So when we look at hemolysis, what we oftentimes do in the lab is we look at a visual inspection to see whether or not the sample is hemolyzed or not. And again, that could be subjective in nature, because I could see it as a hemolysis index of 1, and my colleague could see it as a hemolysis index of 2. So therefore, it becomes a little bit challenging. So each individual person may see it differently. So that's why it makes it very difficult and laborious and potentially prone to errors. But what are kind of the causes of hemolysis? Well, from an in vivo perspective, we look at the hemolytic process, right? We look at severe infections, patient undergoing disseminated intravascular coagulation, or DIC, transfusion reactions, all can result in vivo hemolysis. From an in vitro perspective, it could be a different venopump, right? Using a small needle, where we're causing more shear stress, causing platelets to disrupt not only the platelets, but also the red cells, increasing more hemolysis and hemoglobin in the sample. And this can be about 70% of the samples that are rejected due to hemolysis. Now, what effect do these interferences have on coag testing? We can see here, they can either falsely increase some of your results, or it can falsely decrease some of your results. So again, it depends on which assays are being measured, but you can see hemolysis has a pretty robust effect, either falsely increasing or decreasing some of our coagulation results. Icterus, again, primarily it's visual inspection, looking at how the sample, the degree of yellow that the sample is, you can see, again, could differ from me, from my colleague, and so on. So making the visual inspection extremely challenging and difficult to detect. But we can see from a in vivo perspective, hemolysis could be the result of elevated bilirubin, severe liver disease, something that could cause the excess amount of bilirubin to be present in the human body. but only very few coagulations are affected by icterus. You'll see here, these are some of the assays that could be affected. Your PT, for example, could be falsely increased, whereas your falsely decreased could be your antithrombin. And you'll see here that your APTT doesn't seem to be affected by icterus as much. Lipemia is you get that nice milkshake appearance of the sample. Again, visual inspection can be very subjective, that each person can look at it differently. So it can be challenging to see patients who have excess amount of lipids in their sample. Now, some of the causes, well, the patient can have a genetic predisposition to hyperlipidemia, resulting in a highly lipemic sample. The patient can have a postprandial collection after a very fatty meal, so therefore giving that milkshake appearance. There could be an analytical effect. So it may cause high baseline readings in the assays that read at 405 nanometers. But again, there's a less pronounced effect at higher wavelengths. Or there could be a biological effect where it could affect, let's say, elevation of factor 7, or it could decrease some of your clotting factors. So in the cases of a highly lipemic sample, it's ideal to recollect when the patient is fasting. But what effect does lipemia have on coag testing? Here again, you can see falsely increased and as well as falsely decreased results. Increase would be antithrombin, decrease perhaps could be fibrinogen, thrombin, lupus, and or plasminogen. But your unaffected factors would be your PT, PTT, and some of your factor assays. And I talked about we talked about maintaining that proper fill, right? Ensuring that there isn't an underfill or overfill of the sample. So here we have 4 tubes and we have a fill zone that's typically recommended by the tube manufacturers. As we look at these 4, the 2 in the middle are the ones that fall within that fill zone, right? That 90 to 110%, or 90 to 100%, excuse me. But what happens if we have a sample that's underfilled and a sample that's correctly filled? And why is that important? Well, if you look at the green check mark, the sample that has the standard amount of sodium citrate, once we centrifuge the sample, and we recalcify the sample in order to do a coagulation testing, the amount of anticoagulant there, in this case sodium citrate, is properly distributed. Therefore, you're going to get accurate testing. In the sample that has underfilled, when you centrifuge the sample, because of the anticoagulant in being more than that of the blood, in this case exceeding that 9-to-1 ratio, you're going to have an excess amount of sodium citrate. So when you do the recalcification to run your assays, there's going to be extra amount of sodium citrate that's going to remove the calcium, resulting in your prolongation of your clotting time. So that's why it's important to adequately fill within that fill volume or that fill zone to ensure proper coagulation testing. In the events that your patient has a high hematocrit, sometimes exceeding that of 55%, there is a number of ways that we can use a correction formula, which is indicated here. But most oftentimes what I've seen in majority of the clinical laboratories is they have a table that's already been put out to indicate the volume of anticoagulant that needs to be removed. But again, there should be a standard operating procedure in place for the lab to be able to do this. And these values, I believe, are based on the 3 ml sodium citrate tube that's typically used in clinical laboratories, which is 0.3 ml of the anticoagulant and 2.7 ml of the blood. So again, different labs, different procedures are most likely in place to ensure that they're adequately adjusting, if need be, the hematocrit for the patient. So when we look at improper tube filling, again, you'll see falsely increased as well as falsely decreased results. Here is just an example, kind of reiterating the importance of minimizing these interferences and minimizing the effect that potentially these interferences can have on our clotting assays. So here we have HIL interferences. Of course, we know that hemolysis, icterus, and lipemia can affect some of the optical reading of the instruments that are based on a photo-optical method, as well as if the sample is grossly hemolyzed or icteric. Again, ideally, you should reject those samples and ask for a new sample. Lipemic and icteric samples may interfere If the sample is, let's say, having a different kind of quote unquote fake blood, these hemoglobin-based oxygen carriers that could result in pseudohemolysis. So again, it could interfere with some of our clot and chromogenic methods. I just want to spend the last few minutes on pre-analytical sample integrity challenges or checks that are associated that some automated instruments do in fact have. And what it essentially does is this allows us to improve our workflow, our efficiency, our turnaround time, as well as accuracy and quality of the results that we give. Because when you look at these checks, you're really comparing that manual method versus that automated method. The manual method is really subjective, right? Whereas I could say one thing and my colleague could say another thing. So trying to minimize that is extremely important. And this is kind of nicely illustrated in a study that was conducted in 2016, looking at the three major vendors on that sell coagulation equipment. One is based on a mechanical, and two that are based on a photo-optical. And you'll see in the PTs, fibrinogen, and D-dimer assays that were run here, there are different criteria that was established. Now, granted, one of the limitations of this paper is that it used extraordinarily stringent criteria when it looked at PTs, that is the acceptable variation that you could see. You'll see the red dotted lines on the CS5100 and the ACL Top 550 are the settings that the lab had established of when they would accept or not accept results. And you'll see here in patients who had your PT in hemolyzed specimens, you do see some variation in the instruments, but you'll see that depending on where you set off your checks, you could be preventing erroneous results from going out. But you see that there is a slight effect on the mechanical, but there's a more pronounced effect on one of the two photo-optical methods. The same thing applies for your PTT measurements. You see a general variation, but despite the fact that mechanical is in theory not subject to hemolysis or icterus or lipemia, you'll see here your PTT may be subject, especially in those more grossly hemolyzed specimens. But again, you'll see again the other two companies as well. You'll see that you do have some variation. Again, depending on where you set off your cutoffs is really important. Looking at lipemia, again, focusing in on PTT and fibrinogen, for example, you'll see that there is some variation in your PTT results. And again, more variation either under or over calling. But again, depending on what your acceptance criteria is, it is also independent of the laboratory to say where these checks should be implemented to ensure that we're not reporting inaccurate results. But again, showing the differences in how hemolysis, icterus, or in this case, lipemia, does infect both the photo-optical as well as the mechanical clot detection system. The same thing applies with icterus. You'll see again here, your PTT is somewhat affected by icterus as well as somewhat affected by PTT. Again, indicating that some assays may in fact be affected, some assays may not be affected as much, but again, it depends on the laboratory and what the laboratory is comfortable with and setting up their decision limits on when to accept or reject samples. But one of the advantages of having a system that has a pre-analytical sample integrity check is to be able to remove that subjectivity away and have it done automated on the instrument itself. And these are just two analyzers that the Siemens Sysmex partnership offers for our customers. But what's interesting about these pre-analytical sample integrity checks is the first thing is the sample goes in. At first, it checks whether or not there's adequately filled volume. So it's checking not only for the underfill, but it's also checking for the possibility of an overfill. Once that is completed, a sample is taken, and there's a clog detection, not necessarily a clot detection, right? Because no instrument can really detect a clot. It's checking to see whether or not there's something perhaps in the sample that could potentially influence or affect the coagulation testing. The next step is it runs through these multi-wavelength analysis, very similar to the diagram that I showed when I started off the HIL portion of the discussion. And what this shows is it looks at the different wavelengths to define at what level do I detect hemolysis, icterus, and lipemia. Now, what this does is it minimizes repeat testing and as well as manual reviews, And it removes that subjectivity that the visual inspection typically provides. Once the results are categorized, each individual assay has their own cutoff value for hemolysis, icterus, and lipemia. Now, depending on what those results are, you could either suppress, release the results with a flag, or release the results because there's no interference. So for example, if there's 0 flags, you'll be okay at releasing the results. If, for example, there's a 4 for hemolysis, a 2 for icterus, for example, and a 1, those results may need to be either suppressed because of the hemolysis flag, knowing that some of those assays that were run may be affected due to the high hemolysis index, and therefore those results need to be suppressed. Or again, depending on the comfort level of the laboratory and the medical director, you could either release those results with a flag. Again, highly dependent on the laboratory itself. So these PSI technology allows for quicker decisions, minimal effort, and at the end of the day, better patient care, which I think is the most important thing. And with that, I'd just like to conclude and that we know that coagulation samples are subject to a number of pre-analytical variables. They could be either as a result of patients, sample collection techniques, transportation, a whole slew of variables that could affect. The time from draw to assay is critical for coagulation results. 4 hours, good coagulation, 2 hours, great coagulation. And we know that hemolysis can have adverse effects on our coagulation results. Sample handling can alter results, so depending if there's a significant amount of agitation, anything along those lines could affect your patient results. And again, patient variables, the patient history, that communication between the lab and the clinical staff. And when results don't necessarily make sense, we can consider pre-analytical variables. And of course, I've also been on the receiving end of when an irate physician calls and complains about specific tests, so tests don't make sense. Having that open line of communication, being able to discuss the patient, looking at the results, looking at the patient history, most oftentimes will shed light that there was a pre-analytical variable associated. And the old complaint that it's always the lab's fault is not necessarily true. And with that, I'd like to thank you for your attention, and I'd be more than happy to take any questions if there are any, and if time permits. Thank you.
Thank you, John. We are at a couple minutes over. We can possibly take one quick question. It's really an interesting one. It's a little different than your presentation. The question is, what about pre-analytical variables and the new oral anticoagulants, such as the bigatran, apixaban, rivaroxaban, et cetera? Is there anything you can say on that?
Well, again, this is where I think I've probably said this a lot today, is that it's communication, right? Understanding that the patient's on these type of oral anticoagulants really allows us, or the lab in this case, to focus on the testing and then put in appropriate comments if needed, or if the results don't quite make sense, being able to either address that with the clinician to explain why we can't or why these results are the way that they appear. Now, there are also ways in there that can, in theory, remove some of these DOACs using activated charcoal, for example. But that, again, it all depends on the lab and how the lab decides to move forward with these types of samples. But again, knowing the patient's history, being able to effectively communicate that with the clinical staff, I think is really important and critical to ensure patient care.
Okay, great. John, I have one more. Do you recommend ultracentrifugation to spin lipemic or icteric samples?
So again, this is kind of, I think, a loaded question and also kind of a difficult question to answer, because remember, when any ultracentrifugation techniques are performed, you also have to have the pre and post. So in the event of a highly lipemic sample, the recommendation would be to ask for a sample, a fasting sample, that you're able to draw when the patient is free of these lipids. Now, understanding that that may not always be the case, the lab can go ahead and proceed with an ultrafugation step, provided that they have a pre and post sample available to test both to see if there's any significant changes in the values, and then posting the appropriate results with a comma in the patient's clinical chart, I think is probably the best bet.
Okay, I think that's about all the time we have for questions today. So thank you again, John, for your time and your clinical perspective today. We at Siemens Healthineers would also like to thank the Labroots team for making today's educational webcast possible. Before we go, I'd like to thank the audience for joining us and for their interesting questions. Questions that we didn't have time for today or submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's call. And remember, PACE credits are also available through Labroots. Until next time, take care, everyone. Bye-bye.